So as we complete step 3 of our evidence-based practice steps and critically assess the evidence that we found in step 2, we need to start to create some foundational decisions that will then lead us into step 4, which is when we start to apply what we have found. And so one of the first things that we're going to do with that is we have to assess the evidence that we have found on standardized scales associated with what we term the level of evidence, and then finally to the grades of recommendation. And basically what we'll see with this lesson is that there are ways to take what we have been assessing and start to quantify that with regards to how well we can go about interpreting those differences and the results of the individual studies that we have found to lead to specific recommendations and then interventions that we can go ahead and apply within our clinical settings. So we're going to focus today on what these levels of evidence are and the grades of recommendation, and then we will continue on in how we can go about figuring all that out and then moving towards application. So our main points are to simply describe these levels of evidence, and what these are, as we've discussed previously, is this hierarchy of evidence regarding our ability to interpret what we have found, and then finally describing these organized scales. So when we get into this as a level of evidence and grade of recommendation, and specifically what we mean with these, is the level of evidence is going to be article specific. So for each piece of evidence that we find in our step 2, we are then going to assign it a level of evidence, and this is numerical as far as 1, 2, 3, 4, 5, whatever the standard is that we're using for that, and then go from there into a grade of recommendation based off of all of the evidence that we have found, as well as the clinical applicability of it. The important thing to understand as we go through this is that the level of evidence is independent of the application of that for us clinically. And so the level of evidence would be the same for the article regardless of what our clinical question is, but the grade of recommendation would start to differ. And grades of recommendations are described using letter scales. Now, the other thing to keep in mind is we're going to describe a few different level of evidence scales as well as grade of recommendation scales, but there are literally hundreds of these described in the medical literature, and they're not all the same. So to describe a grade of recommendation or as an A or a level of evidence as a 1 really doesn't mean anything unless we know what group we are using to define those. And so we'll talk about a few of those different groups, but know that those are just a sample of what's available in the literature. So the Oxford Center for Evidence-Based Medicine, or OCEBM, that you may see often in the literature described, is a scale that's been developed for several years and has 5 levels of evidence. This is by far the most common that we see in the sports medicine and athletic training literature with regards to levels of evidence, where level 1 now is going to correspond to the highest level of evidence, and level 5 with the lowest. So you can see here this pyramid, and we've seen a variation of this pyramid before originally out of the Robb book. But when we look at this, you can see level 1 now is well-designed, systematic, well-designed randomized controlled trials and prospective studies. And then they have the different subgroups that have been associated with that as well. And this is the hierarchy as originally described in 2009. In 2011, there was an update to this to deal with the fact that in reality, we can't always get to the true level 1 randomized clinical trials for things specific or for specific questions that may not allow for randomization. And so what they did in this attempt in 2011 is basically take the different types of clinical questions and then define the levels according to what would be appropriate for that question. So if we're looking now at etiology data, or the first part here as far as how common is the problem, you can see that in fact the level 1 is going to be local and current random sample surveys, like census type data components with that, going down to step 4 as case series. So you can see, because we're not trying to determine a causation, there's not going to be a randomization process associated with an etiology type study where we're trying to describe the prevalence with that. If you go down a little bit to the does this intervention help, you would then see this idea of the more standardized components with that, as far as our what looks more like our normal hierarchy. But because in this case, with interventions and treatment benefits, it does allow much more for randomization. In fact, they break this down a little bit, with a level 1 being a systematic review of randomized trials, or this N of 1, which is a special type of trial where basically it's for treatments that have high risks of morbidity and mortality, which has a special study design. You do not often see these in sports medicine components. But then step 2, or level 2, is a single randomized trial or observational study with a dramatic effect. So you can see how these slightly differ from one versus the other. And so even within the Center for Evidence-Based Medicine, or OCEBM component, you really have two different classifications of the levels of evidence. And so although it's important to be able to identify each one of these, and I do recommend that you spend a significant amount of time reading up on these, and there are additional resources available at the OCEBM website describing each component with this. You have to, more importantly than just trying to figure out what is a level 1 evidence level study, but more along the lines of figuring out how can I use each one of these different types of levels within my clinical practice. And so when we look at these, we need to know the generic 2009 OCEBM levels as a starting point, but then you also need to be able to identify that different research article types have different standards associated with them, and what those standards might be. So spend some time with both the 2009 and the 2011 OCBEM levels of evidence. The CEBM grading scale then for bodies of evidence, right? This moves more towards the end of step 3 and into step 4 with these grading scales. But you can see now from the M grading scales, that now this is going to go and describe how confidently we are in our recommendation. So once we get out of assessing the literature in step 3, in step 4 we're moving to apply the literature. So we are apply all of the evidence, right? And so we keep talking about this as the literature, and I even mistakenly describe that as the evidence. But remember, the evidence is much larger than just the literature. It includes your clinical expertise and the patient values. But you're going to eventually get to a point where you need to make a recommendation for what you're going to do. And so these recommendations that are made, if it's just you making a recommendation to yourself, obviously you were involved in the original decision-making process. But in critically appraised topics or different components with like systematic reviews that are helping do this for you, you need to understand how strong of a recommendation that is. And so they have these letter grading scales where A then is consistent level 1 studies, and then it becomes relatively simple, whereas B is level 2 or 3 studies, C is level 4 studies, and D is level 5 studies, right? And if you have consistent evidence, all of the studies are saying a specific thing at the same level, then that's the level you get. The problem comes is you oftentimes have differing results, and so you have to extrapolate from those different studies, and so that lowers it one level. So if you have several level 1 studies saying that something works, but a few level 2 or level 1 studies saying it does not work, you might give that a grade of recommendation of a B. So the strength of recommendation taxonomy, or SORT, was designed specifically to try to create a more uniform method of understanding of these recommendations, but more in family medicine. And so you can see with the SORT guidelines and the SORT recommendations, there's going to be a lot more emphasis on utility of the research opposed to, as in the OCEBM version, the methodological strength. So the components of the strength of recommendation taxonomy, or SORT, there are 3 levels within the SORT guidelines for levels of evidence, and then 3 strengths of recommendations. And the main difference here is, as you can see, is we are first and foremost in the SORT levels of evidence going to describe on whether or not this is patient-oriented or other evidence. And so the idea here is how closely does the information that was obtained in this individual research article match with the patient focus that is going on. So specifically, are they measuring things like patient outcomes or things that are patiently or relevant to the patient? If not, then it would go immediately to level 3. And so examples of this would be more like functional outcomes compared to basic science. So if we were looking at like the ability of ultrasound to treat muscle strains, for example, a study that assessed the ability of ultrasound to increase intramuscular tissue temperature would automatically be a level 3 evidence, despite how high of quality it might be, because intramuscular tissue temperature is not really patient-oriented. Compare that then to a study that would be assessing, say, increases in range of motion, or even better yet, healing or functional activities, which would be more patient-oriented, in fact. And so then level 1 and level 2 just then becomes the difference between what is termed high quality and low quality. And they give some examples there in the areas of diagnostics, treatment, and prognoses on what sort of articles would fall into high quality and low quality. And so you can see the corresponding different types of articles from the CEBM version that are then falling into these 1s and 2s. Right? And then the grades of recommendation follow fairly similar to the levels of evidence with that same downgrading for inconsistent results. So one nice thing here, as you can go through with these, is you can start to take these algorithms that the strength of recommendation taxonomy or sort group has done, and they can then go through and help you in assigning levels of evidence. So you would start first and foremost on whether or not there is even a need for the level of evidence to be given a recommendation. And some types of recommend or articles aren't really appropriate for the purpose of using for evidence, and so you wouldn't need a level of evidence for them. But then you're going to ask the question on basically, is this patient oriented or not, right? And if it's not, then it's level 3, right? Then goes into this idea of opinion, bench research, consensus guidelines, usual practice, clinical experience, or case series. And so these, if you remember, are basically the same sort of levels from the OCBM level 4 and 5. This idea that even though it may be patient-oriented as far as what it's trying to go for, it's not really being driven by either high enough quality, as in like case series, or it's looking at lower level things like bench research, which basically is like our example of tissue temperature with the ultrasound study. And then it goes down and describes basically what sort of things you would be evaluating each research article for in order to then describe whether it's high quality or low quality. Same sort of algorithm is then created for the grades of recommendation as well, where you can see how each one of those grades of recommendation come to be. So lastly, to discuss the comparisons between the SORT and CEBM recommendations, you can see basically there's a decent amount of overlap with that, whereas level 1 studies are going to be fairly consistent between each one, where level 1 studies for the SORT and the CEBM are usually about the same as far as methodological quality, as well as their patient focus. Then grade B, or the level 2 in the SORT, usually corresponds with level 2 and 3, some 4. So C for OCB-EBM is also in there with the B. So level 2 is level 2, 3, and 4 for CEBM. And then B SORT is a B and C. And then a C for the SORT is the same as a D recommendation from CEBM or level 5 evidence. So basically the point is to understand that there is a hierarchy that exists to help us understand these decisions, and then from that how we can go about utilizing those scales to help determine the level of evidence and the grade of recommendation. So next time what we will do is we'll go through several of these checklists that help us determine which level of evidence each article is. But oftentimes, for the newer articles, these levels of evidence are given, which can be very helpful to start with. But next time we will talk specifically about checklists that are appropriate to help us in determining the level of evidence and grade of recommendation.